Thank you very much for that kind introduction, and it's a pleasure to be here. It's really impressive conference, and it's an honor to be a part of this. So what I'd like to do today is tell you a little bit about the Anesthesia Closed Claims Project, it's a study of medical malpractice claims that anesthesiologists have been conducting for over 30 years now. And it's a patient safety project, not primarily a liability project. Disclosures, these are all the sources of my funding. Currently, the Anesthesia Quality Institute funds the Closed Claims Project. It was previously funded by the American Society of Anesthesiologists. I also receive funding from these other sources. And really the story I'd like to relay and give you some history is how anesthesiologists have contributed to this change from death and brain damage being 55 to 60% of their medical malpractice claims down to hovering around 40%. Still not good enough, but at least a vast improvement. And so I'd like to give you some insights into how that has happened, as well as other improvements and how the malpractice claims can be used to improve patient safety. So I'd like to give you a brief history, an introduction to what the project is, talk about just some examples of how malpractice claims have been used to investigate patient safety problems in anesthesia, including death and brain damage, chronic pain management, and burns and operating room fires. It's just some examples of how we've been able to use the claims data to improve patient safety, or at least identify problems in some cases. Just briefly list some other topics we've looked at. So how it all started is in the 1980s, there was a medical malpractice crisis. And malpractice claim insurance was difficult to obtain. The companies were pulling out of the market, and it was very expensive. In inflation-adjusted dollars, anesthesia malpractice insurance was about $41,000 a year, which is actually a little higher than it is currently. So Dr. Richard Ward and a resident, Dr. Richard Salazzi, got the idea that if malpractice insurance is so expensive, maybe if we could see why, what the patient injuries are that are contributing to this, we could improve patient safety, prevent the injuries, and that would solve our malpractice problem. So instead of putting tort reform and limits on it, they would try to take a patient safety approach to solving the medical liability crisis. So they published this, they went out and collected about a few hundred medical malpractice claims, analyzed those in this first little publication. And as a result of that, the American Society of Anesthesiologists president assigned the project to the Committee on Professional Liability. And Fred Cheney, who was at the University of Washington in the anesthesia department, was the chair of the committee at the time. He wasn't really that enthusiastic about the project, but G. Pierce here on the left, the president of the ASA, said, do it, and so Fred Cheney did it. And just some historical perspective, Ellison Pierce, who was ASA president, also started the Anesthesia Patient Safety Foundation at the same time to fund research and join actually with industry and with anesthesia providers and the insurance companies to try to address anesthesia patient safety, and that effort is still going strong today. So what does it mean to do a closed claims project? Well, the objectives were to identify the causes of anesthesia-related patient injury, identify liability risk patterns, and improve patient safety. So we went to the malpractice insurance companies to provide access to their claims. They were not all willing to participate. We use anesthesiologists who are members of the society. They volunteer their time and only get their expenses paid. And they review the claims. They travel to the insurance companies, often taking vacation time out of their practice. We collect about 250 closed claims a year, And by closed claims, these are claims that patients have filed against anesthesiologists. They've gone through the complete process, either been closed for lack of activity or closed because they've been settled or gone to court. And so currently we have over 10,000 claims in this national database. Historically, there have been over 35 insurers that have participated. We now have 20 in an active panel. We cycle through these insurers on a regular basis, collecting newly closed claims. The reason the number's gone down is mostly because of consolidation in the market, although some have dropped out, others add in, but there's also been a lot of companies that have merged together, and some have gone out of business. The companies that are in the current panel insure over 13,000 anesthesiologists, which is about 1/3 of practicing anesthesiologists in the country. So it's not a random sample, but it is a fairly large sample of what's going on in the country. And it has great utility and allows us to identify rare but serious outcomes and collect sentinel events, meaning events that are a herald of potentially larger problems. It's very difficult to study individual outcomes, severe outcomes, just looking at individual hospitals or even groups of hospitals, but by studying closed malpractice claims, you have them all gathered together, and it provides you really large numbers to identify things that are relatively rare but really important. So for instance, in 10,000 claims, we have over 1,000 claims for permanent brain injury. Let's just look at what is the anesthesia contribution to that problem. Almost 700 claims for spinal cord injury, over 600 claims for airway injuries, and 500 claims for difficult intubation. So it takes a lot of claims to have sufficient numbers of any particular problem to really do an in-depth analysis of it and to try to solve the safety problems. Closed claims data also allows us to identify areas of repeating risk, provides direction for in-depth analysis, gives us a snapshot of current anesthesia liability and current anesthesia patient safety. So for instance, here's a snapshot of the most common complications in the anesthesia malpractice claims for events that occurred in the year 2000 or later. So 30% are death, 10% permanent brain damage, 22% nerve damage. Should note that we don't collect claims on damage to the teeth or dentures. That's probably about 25% of anesthesia malpractice claims, but at the outset it was considered not to be a serious problem in terms of patient safety, and they really wanted to focus on the more severe injuries, so we've kept to that. So we haven't really addressed how to prevent damage to the teeth. There are limitations to using this method of studying patient safety. We don't have a denominator. We don't know how many anesthetics were delivered from which these malpractice claims arose. So we can't calculate the risk of brain damage versus nerve injury. It's a small subset of injuries because they're malpractice claims. They tend to be more severe and permanent injuries than you'd find if you looked at hospital data. The less severe injuries often don't make it to a claim. They do represent more poor care, but they're not all poor care. We look at all claims, whether they're paid or not, studies of malpractice claims have shown that most patients who sustain a negligent injury do not file a claim, and many patients who sustain an injury that was not negligent do file a claim. So that's what we're looking at, is the patients who file claims, in a sense, a patient-centered complication study, but it does represent more poor care than good care. So how has this information been used? Well, the American Society of Anesthesiologists has used it to support some of their earliest standards of practice. And I'll explain what some of these are, but in 1990, they used the information we gathered to make the use of pulse oximetry, which monitors oxygen saturation, a standard of care for all anesthetics in the operating room. And in 1991, made it a standard that anesthesiologists had to measure carbon dioxide to make sure the endotracheal tube is in the right place, and in 1992 a standard to measuring oxygen saturation in the recovery room. It was also used to support guidelines. We identified management of the airway as a severe problem leading to death and brain damage and malpractice claims, and this was used to support guidelines for how to manage this situation. Also used for advisories to prevent nerve injury. And it stimulated a lot of research. We're only looking at the cases. Others can take these findings, and it helps identify areas that they should look at, where they can use other kinds of studies to try to investigate the causes and solutions to these problems. So just an example of the changes in standards of practice that this research has helped to promote. So pulse oximetry is a device you've probably, I like to keep this, not making assumptions about your background, not knowing who is coming to the conference. So pulse oximetry uses infrared technology to measure how much oxygen is in the blood. It's just a probe that goes on the finger, and it has a box that reads that out. And it was not available before 1985, and it was not a standard of practice for anesthesiologists until 1990. End-tidal carbon dioxide monitoring, when you breathe oxygen in, you expire carbon dioxide out. And when anesthesiologists insert a breathing tube, which they usually do for general anesthesia, that tube needs to go in, supply oxygen and anesthesia gases to the lungs, and then the carbon dioxide comes out. And before they had these monitoring devices, there really wasn't a good and timely way to make sure that the tube was in the right place. All the ways to check for the tube being in the right place were not very accurate. And even when these technologies came in, there were complaints that they were expensive, they were difficult to use, and so there was some resistance to using this. And the problem being that here's a picture of the patient's airway, and the endotracheal tube, this breathing tube, has to go down into the airway or the trachea so that the oxygen can go in, the carbon dioxide can come out. But as you can see, the anatomy is a little difficult, and the drawing makes it really clear, but if you actually look at it in a picture, it's hard to tell where you are, and sometimes the anesthesiologist can't really see very well. And the tube can go into the esophagus instead, and if it does that, then the oxygen is going into the stomach, not going into the lungs, and in fact the lungs are closed off, and the patient very quickly doesn't have enough oxygen. The carbon dioxide is not going out. They have too much CO2 in their bloodstream, and it will lead to cardiac arrest and death. And without the use of these devices, it was very difficult to confirm where this tube was. You could look, but it's difficult to see, and there are problems with looking. And so the big problem was getting this breathing tube in the wrong place. And before these monitoring devices were available, just getting the tube into the esophagus instead of the trachea represented 3 to 8% of malpractice claims each year for anesthesiologists. And the red arrows show when these monitoring standards came in place, and you can see that the line started dropping before that as the technology became available. But since it became a standard of care, now getting the tube into the esophagus and not recognizing that promptly is 1 to 2% of surgical anesthesia claims per year. That's still unacceptable, but it's certainly a great improvement. And we've just recently looked at those claims to see why this is still happening. And there'll be a report published probably early next year, if not late this year, describing some of the cognitive issues and teamwork issues that have contributed to this ongoing problem. So again, that we can see we can track how the changes in practice have been reflected in these malpractice claims, but we can also see what problems are still continuing and try to look at those to see how else we can improve patient safety. So really the early results that got a lot of buy-in from the anesthesiologists to continue supporting this project, and is completely supported by the American Society of Anesthesiologists and now the Quality Institute, was the reduction in respiratory events and death and brain damage associated with anesthesia. And here's just a graph showing the green line is showing death and brain damage, which has declined significantly over time, and the blue line shows respiratory events, which were the major cause of death and brain damage in the earlier years, and how those have also declined over the course of time. So now I'd like to turn to some other examples. When we look at anesthesia malpractice claims, anesthesia practice has really changed over the years. It used to be mostly surgical anesthesia, but if we look now, what we look at as current practice is really from the year 2000 and later, there haven't been a lot of drastic changes in anesthesia care. So we see that surgical anesthesia is really only 65% of what we're seeing in malpractice claims. Management of chronic pain is 18%, double what we're seeing in terms of obstetric care, so management of deliveries, labor, epidurals, and cesarean sections. And then acute pain is post-operative pain, so treating pain after surgery is 8% of malpractice claims. So I'd like to turn now to look at, when we looked at claims earlier, it was almost all surgical anesthesia care. When we saw these 18% of our claims are related to management of chronic pain, thought we better look at that as an arising patient safety issue. So when we look at trends over time, and these years are the years where the events occurred, what we saw is in the 70s and 80s, pain management was really just a very small part of the malpractice scene, and it slowly but drastically rose up to be consistently 10 to 20% of our malpractice claims. And we don't have a denominator in our database, but we looked at national data from the American Medical Association in terms of what anesthesiologists were doing. And what you see on the black dots in the trend line is anesthesiologists, the proportion of anesthesiologists who are actually practicing pain medicine. So rather than surgical anesthesia, they're practicing either a combination or purely management of chronic pain. And you can see that there's a small rise. It went from about 1% to 3 to 4% of anesthesiologists entering this practice. And then the red line is malpractice claims associated with pain medicine, and that's gone up much more steeply over the same course of time. So clearly there seems to be a mismatch, that the increase in malpractice claims doesn't seem to just be reflecting the change in what anesthesiologists are doing. It seems to be an increased liability and possibly safety problem. And if we looked at the pain claims themselves, the malpractice claims, what we saw is, you see the yellow bars in the 1980s, the blue is the 1990s, and the orange bar is the 2000s. These are when the events occurred, and we see that the outcomes in these claims are actually getting worse. So not only are we're seeing more claims for pain medicine, but we're seeing nerve injury and death related to this practice. So we have 29% of the pain medicine claims are for severe permanent nerve injury, including spinal cord injury, and 19% are death. So we also could look, using these malpractice claims, to see what kinds of things are anesthesiologists doing. And we saw, so basically the pain medicine as practiced by anesthesiologists has to do with injections, usually steroid injections, either into the neck, the cervical area, or the back or the lumbar area. And then they do medication management, which is basically prescribing opioids or narcotics and other medications. And then they also have devices, which are either spinal cord stimulators or devices that deliver medication straight to the spinal cord area. And what we saw there is that one area is medication management seemed to really be increasing over the decades. So we've looked at actually all of these areas in terms of what the changes in liability have been, but I'd like to just talk today about medication management, because you're probably aware that nationally drug overdose deaths have hit record numbers, and these mostly involve an opioid or narcotics. Nearly 500,000 people have died from drug overdoses, and the overdoses are often from prescription pain relievers. They're a driving factor in this increase in opioid deaths. And many of these opioids are being prescribed by anesthesiologists, not all, but many are. So we looked at malpractice claims associated with this medication management, mainly opioid prescriptions. And we knew that opioid prescribing was common in pain management, but we had never looked at this in the past. So what we looked at here is, on the one pie, we look at medication management claims, and we compared them to other pain management claims, so other malpractice claims against anesthesiologists who are managing pain. And in the medication management, 57% of these claims had to do with death of the patient, which was very different than the other claims that only had a 9% death rate. So that's one reason we looked at this, is clearly not only was medication management increasing, but that had a high death rate. So it was a serious patient safety concern. So I'd like to go through some of these just really briefly. It is not surprising that many patients were male, often had a risk factor for dependency. But I'd like you to look at the bottom 3 lines on this table, because we looked at whether the medical management by the physician was appropriate or not, or whether it was a patient compliance problem, say taking too many pills, or differently than prescribed, or taking other medications on top of their opioids. And what we found is in 45% of the cases, it was both the physician and the patient that were involved in causing the poor outcome. 24% were only patient compliance issues, 14% were only physician issues, and had to do with overprescribing, not coordinating care with other physicians. So it wasn't patient medication, seeking medications from multiple doctors, but not coordinating the care of the patients. So this is a way that allows us to hone in on what the safety problems is and target on where we might be targeting solutions. So here you can see that 45%, both the physician and the patient were not doing things right. So really only 18% were other issues, and most of them had to do with either physician or patient management. So, I think the important message here was that, and there was an assumption, especially at this time, that it was really the patient misusing their medications that was the problem. And what we identified is really we had both problems that had to be addressed to solve this issue. So now I'd like to just turn briefly to what we've been looking at in surgical anesthesia claims. They do represent 65% of the malpractice claims. And just give you an example from a topic that is easy to clinically understand, and show you how we can see trends over time and try to focus patient safety efforts. So in the early 1990s, we noticed there were quite a few claims for burns to the patient. And we knew that maintenance of body temperature is an important part of anesthesia management, but those methods could cause burns, and there were a few reports in the literature, so we thought we should look at those. And what we were surprised to find out is that most of these burns were not from devices that were designed to warm the patient, but were from heated materials being placed on the patient. By we mean heated materials, most of them were IV bags or bottles that were put in the operating room oven to warm them up and placed on the patient. And there were also hot compresses. And a lot of these were being used because the patient was cold, and they would put a hot bottle under the drapes to make the patient feel warmer, and then lo and behold, you'd end up with a burn. or sometimes they were used to facilitate IV placement by putting or if there was an IV infiltration, they would put a hot compress or a heated bottle on the area to try to treat that and actually make it worse by causing a burn. So the literature was basically silent on these kinds of complications. Bags and bottles were being warmed in the oven, applied to the skin. In the devices that were actually intended to be used to warm a patient, most of those cases had to do with patients who were at high risk for burns. They had thin skin, not good circulation, older patients, but there was also some misuse of that equipment. So the conclusion was that IV bags and bottles warmed in the oven are a hazard to patients. They're not a good way to warm patients, and there's little justification for using them. If a patient is cold and you need to manage the temperature, you should use the appropriate equipment. So about 10 years after that, a resident came in, an anesthesia resident, and said, well, let's look at what's happened in the meantime, and looked at what's happening with burns. Have we solved the problem? And we can see that in this bar graph, the the red bars are malpractice claims that occurred before we published the report on burns, and then the orange bars are malpractice claims that occurred in the 10 years afterwards. And what we see is that burns from IV bags and bottles went down, and that's a good thing. But all of a sudden we saw cautery fires, and that was a big surprise. So, and that difference was statistically significant. So, there's this change, and we say, well, how do you cause a cautery fire? Well, we know that to create a fire, you need three things. You need oxygen, you need some kind of fuel, and you need some kind of heat source. So this is a traditional, what they call a fire triad. You need an ignition source, something to cause a fire, and in most surgical procedures you have a cautery. It's very hot. That's its purpose, and so it can cause a fire. But you also need oxygen, which can be either oxygen or nitrous oxide, has enough oxygen in it to sustain a fire. And then you need a combustible substance, something to catch on fire. And it was assumed that substance was probably alcohol-based preps that were used to clean the skin before surgery. So let's see. My colleague, Dr. Bonacker, who was starting to look at this problem, we went to the university, said, we want to see how you start a fire on a patient. They said, no, you can't do that. Sorry, against the rules. So he went out in his yard, and he set up a table, and he got dressed up, and he set up his video camera, and he got a little cautery. And what he has there is he has a surgical drape over the table, he has no patient under it, thank goodness. And he put a little tube with oxygen flowing, basically a nasal cannula, so a very small tube, not high flow oxygen, and it's underneath right where he's pointing with the cautery with some oxygen flow. And I don't know if I can make this work or not. And poor Dr. Bonacker got a real surprise. So in less than 2 seconds after touching that cautery to the drape, he had a big flame in his face. Now, sorry the video wouldn't work. We really enjoy seeing poor Dr. Bonacker jump up in shock. He only got one take. So that's how quickly you can get an operating room fire. There was no alcohol prep. It was simply a surgical drape, oxygen, apply the cautery, and there it goes. And you can imagine if that's on the patient, certainly you're going to get a burn there. So we decided we better look at these in more detail, because we don't know what are the relative importance of the different factors that contribute to the fire in that fire triad. We knew that fires were increasing tremendously over time. And we looked by type of anesthesia, and this was a little surprise. So it wasn't, in the pink bars, which you can hardly see, are general anesthesia. And that's where you have the in general anesthesia, that endotracheal tube is delivering oxygen into the airway. It's a closed system, so the oxygen is not flowing out into the room. It's going into the patient. MAC is monitored anesthesia care. It's basically sedation. And during sedation, excuse me, the oxygen is usually flowing through some nasal cannula open to the face. And actually studies have shown that you get quite a buildup, even with no drapes, of oxygen just around the nose area, larger than you'd expect. And what we saw is these cautery fires were occurring during monitored anesthesia care, representing 31% of all our monitored anesthesia care malpractice claims since the year 2000. So, and in addition to this, monitored anesthesia care claims were increasing, and it's an increasing technique used by anesthesiologists. So when we looked at 100 of these claims in detail, what we found is electrocautery was almost always the source of ignition. There were a few other sources. It was masks and drapes that were the fuel. It wasn't the alcohol prep. And that's probably because the operating room team knows that alcohol can catch on fire. They know that alcohol prep is not really effective if you don't dry it. So that's sort of out of the picture by the time the surgeon starts working. And supplemental oxygen was always the oxygen source. So the American Society of Anesthesiologists published a practice advisory for prevention and management of operating room fires in 2008. We're still seeing fires after that time. They've updated their advisory. This is what they were advising in 2013, is to place the drapes open to room air so the oxygen can vent out, is not trapped under the drapes like it was when out in Dr. Bonacher's yard. Allow the skin prep to dry. Put moistened sponges near the cautery. And I think very important, the surgeon needs to give notice before he uses the cautery to the anesthesiologist and the whole team. And then they need to stop or reduce the oxygen delivery to the minimum requirements. Stop nitrous oxide, wait a few minutes for the oxygen to dissipate. And if you're going to need a lot of oxygen and can't do that, maybe you need to consider a general anesthetic, not sedation, and use an endotracheal tube where that oxygen is trapped in the tube and not going to present a fire risk. So this is just an example. I asked anesthesiologists, we want to take some pictures of open draping, and surprisingly, many of them didn't know what that looked like. So this is what it looks like. You need to have the drapes open. Oops. So the oxygen is not trapped. Most of these procedures are happening on procedures on the face and shoulders, and the typical surgical draping is to just cover all the areas, and often the oxygen was being trapped under the drape. So you can open these up and still have that separation. So what we could tell anesthesiologists is that most fires are occurring in monitored anesthesia care with open oxygen delivery in these upper chest, neck, and head procedures, and that they need to follow the practice guidelines and have communication to try to prevent these fires. So in closing, there are other topics we've looked at. These were just some examples to show you the power of using malpractice claims to identify changing trends in patient safety so that it can stay on top of these problems. We've also looked at massive hemorrhage, looked at postoperative respiratory depression, where people are found dead in bed the day after surgery, associated with getting pain management. We looked at changes in obstetric complications over time. And lately we've tried to also turn and look at human factors such as situation awareness in the operating room, looking at communication, not just in fires. Many of our communication problems have to do with not communicating about fire risk, but any communication problems in the operating room, which actually contribute to about 30% of malpractice claims. And an important lesson we found is once you start looking for something systematically, you start identifying it, and our anesthesiologists see these things, and then we can alert the rest of the community about these problems. It's a study, so the lessons we've learned is a very effective study of rare events, relatively low cost compared to, say, federal grants. It improves patient safety for the specialty. It's interacted with practice guidelines and parameters, addressed many of these problems. And this is our website, which unfortunately is broken today. So check back. Hopefully it'll be fixed very soon. Also have some other patient disease or injury registries. So thank you very much.